Welcome to the STAR presentation of opiate use disorder in adolescents. I'm Dr. Bellelizabeth Foster, presenting from UNM Department of Psychiatry, a current presentation created by both myself and Dr. Russell. At this point, as an introduction, I am the medical director at the Adolescent Treatment Program at ASAP. My background is that I graduated as a nurse from San Francisco State University in California, and then went on to medical school. My specialty is child and adolescent psychiatry, and I've worked both on the Navajo Indian Reservation in Chinle, Arizona, and then went on to work at Marshfield Clinic in Wisconsin. I returned after 10 years of practicing to University of New Mexico to complete an addiction fellowship. I ended up staying on as a provider to help create the adolescent treatment program. Disclosures. I have no financial disclosures. At times, I use brand names. It's just very common for our patients to refer to different substances and medication in that form. For example, Suboxone is buprenorphine naloxone. You'll hear patients talk about Xanax or Xanibars when we refer to them as alprazolam. It's just important for you to know both names so patients are included in the conversations that you have. The goals and objectives for this presentation is to identify how changes in the DSM-V will impact the diagnosis of adolescent substance use disorder, understand the epidemiology in New Mexico in comparison to the United States for our adolescent youth population, understand the factors contributing to the opiate epidemic, be familiar with the diagnosis and treatment for opiate use disorders, and become familiar with pharmacotherapy for opiate use disorders. I also feel that the other underlying goal for this presentation is to understand that addiction is a brain disease and that it's important for us to treat it as such. These are important concepts by Nora Volka. She is a doctor and also the director of the National Institute of Drug Abuse. She has two important quotes that emphasize this, in that we need to consider and conceptualize addiction as, knowing that drug experimentation and recreational use are volitional, but after addiction develops, the control is markedly disrupted. And despite our conception, willpower alone is not going to be sufficient to overcome an addiction. And due to changes in your brain, we actually lose the ability to just say no. This is an important slide, and it's from Dr. Grutenoff's website, learnpsychiatry.org. It explains a visual of the changes in substance abuse and dependence from DSM-4 to DSM-5. One of my adolescents pointed out that it goes from a flip phone to an iPhone. So when looking at it, because of changes, it's going to impact the diagnosis. So under substance abuse, it listed a failure to fulfill obligations, continued use, frequent legal problems, and recurrent use when physical hazardous situations. It also went on to say that substance abuse met the criteria that are still carried through to substance use disorder. One of the things we removed was frequent legal problems. And the other thing that we added was cravings. And so now you can categorize the criteria under social impairments, risky use, impaired control, and pharmacological criteria. You do have to meet 2 of the criteria over a period of 12 months. The addition of cravings is really helpful and adds an important concept to the diagnosis. But when you're looking at what the loss of abuse is, you have to understand that this is going to change. For example, we've now moved on to specifiers that say mild, moderate, and severe. This is complicated because once you've met criteria for mild, moderate, or severe, that is the diagnosis and specifier that stays with your client. So labeling someone substance use disorder severe, as they improve, they don't change to moderate and mild. It can also add a distinction to adolescents and a label to adolescents that we have to consider carefully. DSM's removal of abuse categories shows that we're going to miss problematic substance use. Because of this, we're missing kids that can still have neurocognitive damages that are going to disrupt normal social development. So when you're going through any screening tools, and we'll cover this later, and you find, okay, they don't meet criteria, you have to step back and understand that binge drinking, although it's once a week or twice a month, doesn't meet criteria. It doesn't mean that you don't need to make an intervention. So remember that adolescents can benefit from treatment, and by having this discussion early and postponing use as long as you possible can decrease the risk of later developing a substance use disorder. Now, this is a slide that you'll see in almost every presentation regarding adolescent substance use. It's from the National Academy of Science. And when you're looking at it, the right, lateral, and top views show a sequence of gray matter maturation. And so over the cortical surface. And so in the left, you see a minimal amount of blue highlights, which show the gray matter in a young brain. And as you age, from the age of 5 to the age of 20, you develop the gray matter. The concept is that in your adolescence, without your gray matter protecting your brain, it exposes areas which increase the risk of damage. This is a creative way to look at the teenage brain, and just a moment to pause, where the frontal lobe is the texting lobe, the temporal lobe is the old people are so clueless lobe. Down into your cerebellum, it's the digital download. Your occipital lobe is either the twilight lobe or mutated from the Harry Potter lobe. And as we look at it, we can see their perspective of the brain and how it impacts their development and our view of them. Adolescents with substance use disorder, and even it's able to say that all adolescents have increased biological vulnerability, as the slides show, impaired impulse control, and increased novelty seeking. Dr. Volkoff also points out when substance use occurs in adolescence, it affects not only normal brain maturations, but also developmental and social transitions. Now, one of the things we talk about is the normal transitions in life and how substance use changes it. We look at delays in graduating from school, going to college, and peer relationships. But I also like to conceptualize how substance use leads to what I call speed forwards their life. Adolescents are that use substances find themselves in adult situations, which increases their risks of making choices that can lead to adolescent pregnancy, sex trafficking, contracting sexually transmitted diseases, increased involvement in the legal system, and a shorter quality and length of life. What are opiates? So opiates are compounds that interact with the opiate receptors. The mu receptors are the primary receptors in the brain. It's important to remember that we have endogenous opiate receptors, and this is what people will talk about a lot of time when they say dopamine, which is the principal chemical in the reward system, will increase and you'll feel better if you exercise, eat a piece of chocolate cake, and also including sexual encounters. But also they're activated in response to pain and stress, as well as involved in mood regulation. But when we talk about opiates, these are the images that come to mind for me. What are the images that come to mind for you? There's clear definitions of opiates, and just for understanding the literature and different classes of opiates, we can think of it this way. An opiate is actually something that at times you'll hear referred more often than opioids by our patients and clients. Opiate actually comes from the opiate and poppy, and these are morphine and codeine are examples. And then opioids are semi-synthetic, which come from morphine, codeine, thebaine, and those are heroin, oxycodone, hydrocodone, and actually buprenorphine, and we'll come back to that. And then there are fully synthetic opiates, fentanyl, methadone, tramadol. Because of these classifications, people who are seeking treatment will go on the internet and they'll see that buprenorphine is an opioid and methadone is a fully synthetic opioid. And so what will happen is they'll get this perception that you're substituting heroin for methadone or Suboxone, buprenorphine. So what you have to do is take the next step and look at the receptors that we reviewed and know that these medications are what we call full agonist, partial agonist, and antagonist. And when you use an antagonist, that blocks the receptor and it has an impact on how you experience the medication. So buprenorphine and methadone do not give you the same high, as we call it, as heroin, oxycodone, and it actually is protective in the sense that it will keep you from experiencing the high that we find in other substances. So let's move on to prescription opiates and opioids, because if you think back, both morphine and codeine are available prescription, and the rest are referred to as opioids. They're used as primary clinically for pain relief. They're agonists at the mu receptor, and they cause the side effects of constipation and respiratory depression, to name a few. They're classified. We have Schedule 1, which aren't available except for special exemptions, for example, heroin and LSD. There are Schedule 2, which are high potential for abuse, which are many of the opioids and stimulants. Schedule 3 is believed to be moderate potential for physical and psychological dependence, and this can include Tylenol with codeine, ketamine. Schedule 4 are considered low risk of dependence or abuse, and that would include tramadol, benzodiazepine, zolpidem, which is also called Ambien, and carisoprodol, which is called Soma. Schedule 5 are considered the lowest potential for abuse. Lyrica, pregabalin, Imodium is Lamodal, and some cough syrups. But what is our shared clinical experience? For example, hydrocodone, acetaminophen, also known as Vicodin, has now been moved to a Schedule 2 because we found that it is highly addictive. And when you look at benzodiazepines and Zolpidem or Ambien, they have a higher level of abuse or dependence than its schedule suggests. This is even recognized by the CDC because there's now increasing awareness about the risks of accidental overdose. Now we are also concerned about atropine, Lamodal. We're concerned about gabapentin, and gabapentin isn't even scheduled, and now we're seeing emergence of abuse. Why are opiates addictive? Well, they create a euphoric effect. They activate the reward systems. Kids will say it is the best feeling, their first dose, that they've experienced. Then you move on to tolerance, where it requires increasing doses to feel that euphoria. And as you move towards the next piece, where your tolerance exceeds your ability to actually feel good, and you begin taking the medication to not feel bad, which is where you begin to experience withdrawal symptoms. Opiates with a shorter half-life and a rapid onset of action are more addictive and reinforcing, such as heroin. And it's always important to remember that illicit opiates and prescription opiates have the same addictive potential. And at this point, I just want to pause and say to be reminded that tobacco, cigarettes, e-cigarettes are highly addictive because they have direct action on the areas of the brain that release dopamine. And within 10 minutes after smoking a cigarette, you can experience nicotine withdrawal, which is why it's very difficult to quit smoking. And in our young people, as we move from the recognition that cigarettes are harmful, but e-cigarettes are not, it's important to keep that in mind. Epidemiology. Now, this is my favorite slide. It's from a community organization called Guiding Communities to a Vibrant Future. They created this slide to point out that most youth don't use. That 30-day use of the following. Notice alcohol is decreasing use, 30% of use who use alcohol. It's slowly going beyond 20%. Cigarettes are also declining, as I discussed. Marijuana has increased, and prescription drugs are now being monitored. The realization or belief and understanding of the harm of these substances has contributed to the decrease in their use, but we do not monitor e-cigarettes. And e-cigarettes contain nicotine as well as other substances. And because they're not regulated, we do not always know what the additives are to e-cigarettes. New Mexico Department of Health publishes statistics, and in comparison with the throughout the United States, alcohol is the most commonly used substances in New Mexico, and 26.1% of youth have had or used alcohol in the past 30 days. 25% of our youth in comparison to 22% of US, and 4.4% report a lifetime use of meth, which is greater than the 3% throughout the United States. Heroin is reported at 2.8% in the last 30 days, with a lifetime use of 3.5% as compared to throughout the United States of 2.1%. And opiate painkillers have the third highest prevalence, and as you note, 7.9% report the use of opiate painkillers. This is a geographical map that comes from the New Mexico Department of Health. It shows throughout the counties what the heroin use is at least once a month. And if you'll look at some of the counties, Luna is 6.1%, and Bernalillo County is 2.1%, Rio Arriba is 3.7%. One of the things that recently was pointed out to me when looking at these statistics is they're for kids that are in high school. And because of the large percentage of our adolescents that are not in school, this is not reflective of all youth in New Mexico. This is the prevalence of painkillers used in the last 30 days. And again, Hidalgo County, Otero County, Roosevelt County, some of your outlying counties have a high rate of use. McKinley is 12.3. How did we get here? Now, most people discuss, the Joint Commission accreditation of pain as the fifth vital sign. And with the use of pain scales, we started identifying pain and treating pain. Now, based on my history and going back to my nursing days, this is not the only source. It began prior to that. First, in 1986, for example, in the Journal of Pain, they talked about the safety and effectiveness of prescription opiates to selected patients. Prior to that point, we didn't even recognize that infants, children, and adolescents experience pain. And this identification has also led to an increased opiate prescribing in all demographics for both acute and chronic pain. There's also the contribution of the growing pharmaceutical industry creating and promoting the use of a variety of opioids and opiates. Opiates also have the number of largest new users beginning in 2006. There's also an increase in prescriptions for adolescents, and there's the parental expectation of opiates for treatment. I'll often hear comments and concerns from parents that if their child has an acute urgent need or chronic pain, that they are upset and disappointed in providers for prescribing NSAIDs, physical therapy for treatment versus opioids and other prescriptions. New non-medical users of prescription opiates increased from 600,000 in 1990 to over 5.2 million in 2006. Trends in opiate abuse for adolescents is, as stated, the increased use of prescription opioids, increased emergency visits for result in prescription of opioids, which doubled from 2004 to 2009 and accounted for 20% of adolescent opiate abuse treatment admissions in 2000, whereas now it's increasing up to 67% in 2010, and it is ever growing. This is data from the American Academy of Pediatrics, and what this shows is that escalation of use up to the age of 2006. You see all controlled substance opioids, sedative hypnotics, which are benzodiazepines, and stimulants. Now, when you consider the controversy over stimulants and treating adolescents with ADHD medications, which are stimulants, you see that the attitude and expectations of opioids is different. They're acceptable in a variety of contexts. Adolescents, parents, community members will not have the same discussion until recently about opioids. The other concern is, as you see, the increasing use of benzodiazepines in adolescents. Now, when you look at this, you're looking at another example of controlled substance prescribing, and it separates out, but still shows that opiates are being prescribed at higher rates. Now, this is an example of a visit to emergency room that was presented in the Pediatric Journal of Medicine in 2010. And what this shows is it shows visits to both outpatient and the emergency department and the reasons why opioid prescriptions were given. One is the highest is muscle and back pain, musculoskeletal and back pain, which we know in adults is not an effective treatment, and physical therapy is the preferred first choice for treatment of this pain. Injuries, they're also given in follow-up, psychiatrically for insomnia, and as you see, the growing use of opiates in adolescents. Diversion is a concern that we have to address in the terms of moving one prescription drug from a lawful to an unlawful channel. And this will happen with substances where, which we'll talk to in the future about medication that's given for an orthopedic procedure can be diverted to another source. The prescription drug diversion is estimated to be a $25 billion a year industry, and there are many routes: theft, forgery, fraud, and also cross-border smuggling. And most recently, we've talked about the dark web and being able to purchase substances such as fentanyl from other countries and have it actually mailed to people that order it. I want to emphasize what I call don't forget the leftovers, and this is because of the supply in medicine cabinets. In 2017, a study just looked at the oversupply following a surgical procedure, and 67 to 97% of patients reported unused opiates, but only 4 to 30% in this evaluation even considered the disposal of these unused medication. Now, this is kind of an idea that we as providers don't think of. Like, one, you want me to throw out my medication, and because of the cost isn't the only reason. But now we're restricting the availability. Actually, one of the women that I work with went to her doctor and has had been on hydrocodone, and the doctor said that she wasn't going to be able to continue to prescribe it for her. And so she began hoarding the Vicodin that she got from one provider to treat another disorder. So the prevalence of unused opioids, it's demonstrated in general surgery, dental surgery, dermatological surgery, and orthopedic surgeries are high. And they're more than 15 tablets at a time. Now, this is being addressed through education, but also insurance companies are beginning to limit the amount of supplies after a procedure or ongoing. Now, we talked about what happens to unused medications, and it's important to look at this slide because 55% of adolescents received their opioids from friends or relatives. The next largest source is having them bought from a friend. 4.8% actually took them from a friend or relative, and 4.4% obtained it from a drug dealer or a stranger. But, that purchase of that were bought from friends kind of makes you look at the fact that 17.3% were prescribed by a doctor. Prescription opioids are perceived as more acceptable, less dangerous, less subject to legal consequences. They're prescribed by a doctor. And when you think of adolescents, they think, okay, they are mine. So if you take, you get a prescription for Vicodin or hydrocodone from your dentist, and then you later develop a headache, in their head that's not considered inappropriate use of their medication. Now, risk and protective factors for drug abuse and addiction, and this comes from NIDA. The risk factors, which we see in a lot of our youth that we treat, are aggressive behavior in childhood, lack of parental supervision, poor social skills, drug experimentation. And if you go back to that idea of Nora Volkoff, where she said, drug experimentation can move on to substance use. The availability of drugs at school and community poverty. We just had a discussion about La Cueva High School in Albuquerque, and one of the patients that we're treating said that one of her triggers is that everywhere she goes at school, she can purchase opioids. Protective factors are better self-control, parental monitoring, and support. And this includes parental monitoring of the medications that adolescents get. Often with stimulants, parents will say in kids as young as 12 that they're responsible for monitoring and taking their medications. Positive relationships, doing well in school, activities in school regarding policies, and just overall neighborhood pride, more resources. If you have increased risk also if you have repeated non-medical use of substances or prescriptions, onset in adolescence, ongoing adult illicit use shows substance use beginning at the age of 16. The earlier the onset of substance use, the greater severity, increased morbidity, and predicts polysubstance use. You need to look at comorbid psychiatric disorders and a family history of substance use disorder. And this family history also should include ongoing use of family members, but we'll talk about that later. Progression to heroin use. So basically this slide is showing that heroin use is on the rise. And the majority of adolescents started using prescription opioids. And what happens is that it becomes more expensive. One of the roots of opiate abuse and heroin use is by smoking, and kids will think that if they smoke heroin, it is not as dangerous, or they don't consider it a drug of abuse at the same degree as they do IV heroin use. The other concern is that oxycodones or other opiates become too expensive, and adolescents move on to heroin. The severity of substance use correlates, as we said, with worse outcomes. And this is based on the DSM-IV, where we talked about comorbidities and the use by kids that aren't in school. Adolescents who were categorized as dependent had comorbid depression. They sold illicit drugs, and they used multiple drugs in the past year. What are the consequences? I always find it interesting that we begin with the financial costs. Overall, it's considered a huge cost in the billions in areas of productivity, healthcare, and in the criminal justice system, which is actually, this is a study from 2011, and it is growing, and the costs are greater in that system. Public health cost, increased healthcare utilization, worsening risk of infectious disease. Emergency departments for non-medical use. If you look at this study from 2011, you see that in 2005, age 12 to 17, rates per 100,000, it continues to grow to a significant manner. And in ages 18 to 25, it's gone from 87 to 200. Now, we've talked about this the impact on social development and neurodevelopment. And this is just another presentation of this slide showing the growing gray matter and the greater protectiveness of the gray matter. Opiate-related overdose and deaths are on the rise, and to me, that's the most significant consequence. The trends, just in general, for adolescents, overdose deaths increased by 19% in 2015, and the majority, almost 80%, were unintentional, but female overdoses were twice as likely than male to be suicides. The death rates for drug overdoses among adolescents were highest for opiates, but next is the combination of other substances. This is, I really encourage you to go to YouTube and upload Kendra Crooks's documentary from 2012, and it talks about the growing overdose deaths in high schools throughout Albuquerque, and it gives you a perspective of when this began to be a concern, a public health concern. This is the drug overdose deaths per 100,000, and it's age adjusted. And if you look at New Mexico all the way up to 2016, it's higher, significantly higher than the United States. Now, we are leveling off, and actually news reports indicated that, the rest of the United States is catching up with us. But at the same time, catching up with us with such high rates doesn't steer us away from the fact that we still have higher overdose rates. And this comes from actually the New Mexico Department of Health and the CDC. So this is just, if you go to the behavioral website and you type in overdose deaths, this comes in, and it breaks it down by sex, race, age. And if you look at a combined all sexes and races, you see that the light blue shows ages overdose on age 0 to 24 is not as high as ages 65 and plus, but the greatest risk is for ages 25 to 64, which is reported in 24.7 per 100,000 and 26.8 per 100,000 for all ages combined. White and Hispanics have the most due to drug overdose. Overdose deaths in teens. This shows the total amount and comes from the National Center for Health Statistics. And overall, it shows total male exceeds female, despite, varied reports from other sites. This is where we need to look back at the difference between what we call natural and semi-synthetics. When you look at the bottom black line, you'll see synthetic drugs, excluding methadone, that has made a marked rise in 2015. I'm really interested in the statistics over the past 3 years because as fentanyl has come on the market, I believe it's a lot higher and has greater impact than we've noted so far. Overdose related to methadone is on the decrease, but overdose deaths related to heroin are on the increase. And if you look at the top darkest blue line, it's natural and semi-synthetics, including heroin, are on the decrease. So when you look at semi-synthetic, you're looking at, remember we were looking at fentanyl and actually including tramadol. This is clearly a serious issue, so what can we do? Naloxone, it's a rescue medication and can reduce deaths from overdose. It's important for family, friends, associates also to be trained. That includes community members, police departments, fire departments. It should be everywhere in our community, just like we have defibrillators. It's a good idea to ask your patients, have you ever witnessed an overdose? Have you ever overdosed? What did you do? Do you or anyone else you know have naloxone? And then is there anything you would like me to teach you about naloxone? I think you have to be careful with the question of what did you do, because that has a negative connotation. Some people feel very guilty that they didn't call 911. Some people left the scene. Some people didn't understand or know about naloxone because of education. So thinking about a way to ask this question non-judgmentally is important based on your client population. What did you do in that situation is hard to think about, and it actually stays with people for a very long period of time, like I discussed. This is really important. This is a study that talks about the overdose reversals by county. And it really shows when you look at Bernalillo, Santa Fe, Rio Rebro, the significant reduction in loss of death. Prevention, educating parents and guardians about the dangers of not securing prescription opioid medication, and really encouraging locking the cabinets and supervising them. Community education regarding the signs that could indicate adolescent substance use, a change in behavior, peers, grades, school attendance, relationships. But it's important not to jump just to this conclusion, because it could indicate depression, an emerging psychiatric disorder, family discourse, abuse, social determinants within the community, and history of learning disabilities. One of the things that I've noticed in this community and my practice is that ADHD and learning disabilities are underdiagnosed and can lead to adolescents leaving school earlier and earlier involvement in substance use. Screening, the great opportunity is at routine annual medical visits with adolescents in the primary care setting to make sure you present the screening questions in a non-judgmental manner, which is directly related to tone, and make sure you have a discussion with adolescents about confidentiality. You have to be careful about increased rapport building, because you will think and you will know an adolescent, if you're in primary care, for a longer period of time, and they might not tell you about their substance use because they don't want to disappoint you and because they are ashamed that they are using. The craft screenings interview, I think, is most used in the community and as part of expert trainings. It stands, we'll go through what the craft stands for, but the three basic questions are: did you drink any alcohol more than a few sips? Did you smoke any marijuana or hashish? Did you use anything else to get high? And anything else includes illegal drugs, over-the-counter and prescription drugs, and things that you sniff or huff. Part B of this is, if they answer no, then you ask the car question only and then you stop. Have you ever ridden in a car driven by someone who was high or has been using alcohol or drugs? And if they say yes, distinguishing, was it peers, was it family members, can help guide you in a different direction as well. If the patient answers yes, then you go on to the craft questions. And if you look at the letters, it's car. Do you relax? Have you ever done it alone? Do you forget things you did while using? And have you gotten into trouble while you were using alcohol or drugs? So this is kind of the scoring, and you can look at the degree of problem related to alcohol or other substance use. Each question will get a point. 0 to 1, no problems reported, none at this time. 2+ is a potential of a significant problem, and assessment required. You don't want to just move forward. You want to also give positive reinforcement for non-using, and following up with questions about why do they think in the growing age of adolescent substance abuse, what are the things that have helped them be able to maintain this use, maintain not using substances, and what do they consider risks for actually using substances. You have to go beyond screening and develop conversations so that the adolescent can share other concerns with you. Evaluation and diagnosis, you want to do your history and physical, which is no different than your primary exam, but be sure to include labs that are beyond what you would normally get for a developmental age recommendations. Be sure to get a CBC, a Kim 7, a TSH looking at depression, liver function tests, which can kind of guide you in terms of acute damage for binge drinking as well. You want to also test for hepatitis C antibody and follow up as needed, HIV, chlamydia, gonorrhea, and syphilis. Psychosocial assessments to me are important to not only identify strengths and weaknesses for that person, but also to evaluate social support, living situation, transportation. Comorbid psychiatric disorders, other substance use, history of abuse, and a trauma history. And when you're thinking about trauma history, it's not just, direct witnessing of harm. For example, right now, because of DACA and risks of deportations, adolescents have the potential to lose teachers, peers, parents. And so this is an example of beyond the typical trauma that we are used to asking. In assessments, you want to address current use in opioids or any substance, the age of first use, how did it begin, type, amount, pattern, route, and like I said earlier, what is their perception? If they're smoking heroin, are they also using meth? You want to know when you're evaluating them, are they intoxicated or in withdrawal? And as you go through this assessment, you're asking yourself, do they meet criteria for an opiate use disorder? If they don't meet criteria for this, then what interventions can you make that are going to lead you to an intervention to prevent opiate use disorder in the future? You also want to say, do they agree with you? Do they consider it a problem? And if so, do they want to, or are they motivated to change? The concurrent medical illnesses we talked about, and really particularly paying attention to benzodiazepines and alcohol because of the increased risk of overdose, accidental overdose due to respiratory suppression. One of the special, unique aspects that in New Mexico and in other areas, but are noted in our patient population is the multi-generational use. We have currently multiple families where you have the grandmother, the parents, and the siblings with substance use disorder. So your grandmother could be on methadone and stable, your parents could be on Suboxone and not stable, and your siblings can be using. So when you're assessing social situations, who is your client going to be living with, and what are ways to minimize their exposure to other substances? Treatment needs to be evidence-based, individualized, and take place in the appropriate treatment setting. You have to also consider the level of development, and it doesn't always match the chronological age. We fortunately have the ASEM criteria, which helps determine the level of care. I won't go through all of the criteria. I will note that ASEM training is available through CYFD, and you can contact them and see if they have a training in your area to help you work through this criteria. So some definitions: abstinence-based treatment, I'll follow up in a moment. There's behavioral interventions, including cognitive behavioral therapy, psychosocial interventions, family-based therapy, relapse prevention. There's medication-assisted therapy, which is really includes methadone, buprenorphine, naltrexone. But in the adolescent population, we're moving more to the referral of buprenorphine and naltrexone as relapse prevention medication because of the stigma associated even in adults with methadone use. Abstinence-based, for opiate treatment programs, we have to show guidelines that say you have 2 episodes of trials of abstinence-based treatment. And as you know, one of the biggest barriers in our state is the availability of treatment facilities. In other areas, Suboxone in the primary care setting, they don't have to meet this requirement for Suboxone, but you do for methadone. Behavioral, I'm going to cover 3 really prominent programs: the Adolescent Community Reinforcement Approach, ACRA, Cognitive Behavioral Therapy, CBT, and Contingency Management. It's really important to incorporate behavioral interventions and not just relapse prevention. ACRA, their goal is to maintain abstinence by replacing influences in their lives that reinforce substance use. It helps you use processes that develop healthier relationships. Its first step is you want to assess adolescents' needs and levels, and there's more than 17 different treatment approaches that can focus on problem solving, coping skills, communication skills. This is very easy to access. There's trainings available. There's materials on the internet, and it was actually developed by a member of our community in New Mexico. CBT, or cognitive behavioral therapy, this focuses on the learning process and how it plays a role in developmental problem behaviors. First, you identify problems, how they impact your thinking, identify cues and risks, and then this is where you work to develop coping strategies and self-control skills. Contingency management, it is shown that immediate reward for positive behaviors can modify problem behaviors, and they can be very low cost incentive. Prizes, cash vouchers, it can be given for both not only participating in drug treatment, but identifying and achieving important goals. And the best part about contingency management is that it can be used not only in treatment with family. You just shouldn't limit it to only not using drugs. Goals should be appropriate, and steps should be taken, and you should think of rewards for harm reduction as well. Always remember, involving the family can be important in treatment, and they can be very active in helping adolescents achieve treatment. And don't forget to anticipate and manage relapse. Urine drug screen should consistently be used because relapse is a part of recovery. You need to identify relapse early, and you need to adjust your treatment plans accordingly. Always address the relapse directly. Example, Corey, I see that your urine tox screen shows heroin. Talk to me about that. If they argue, it doesn't, or become a defensive, it's not necessary to always confront the issue, but to actually just accept this facts and move on with clear consequences for that positive urine drug screen. Barriers to treatment. Only 10 to 12% of adolescents that need treatment get treatment. There's a reduction in the number of treatment beds, and insurance continues to determine where adolescents can get treatment. Also, perspectives. Adolescents will say to you, you can't make me do it. I don't use heroin anymore, and it can be just a week ago. I'm not taking Suboxone. It just makes me sicker. Family and community members can at times have a limited understanding of addiction as a disease, and also, this belief that it's something that they should get treatment for and get over with. A quote recently is, he's not even trying because he's making the same mistake over and over again. Attitudes for parents, it's not my kid. I think that there's two ways that it's not my kid. One, that they're using. Two, that they need help to stop using, that once it's identified, they can use. And three, that they limit and kind of want to control the type of treatment their adolescents receive. Stigma, the use of addict. We're a part of a program that is housed in an addiction program that includes adults with long-term substance use, and adolescents will say, well, I'm not an addict like them. Also, we normalize drug experimentation and don't always identify problem behaviors early enough. And there's the concern that medication-assisted therapy is going to hurt their brain. And it's not even just for adolescents, it's for adults. Like I said earlier, the belief that methadone and Suboxone is replacing one drug with another. So this is kind of an active way that our community in addiction, psychiatry, and medicine are trying to teach community members that drug use is a disease. Now, this is a PET scan, and it shows, you can just look at the colors and really see on the left, they're trying to show you a healthy brain and a healthy heart. And as you move towards the right side, you see a diseased brain of someone who has cocaine and a diseased heart. So the heart is the easiest to visualize because the red area in this picture shows a healthy heart that's actively metabolizing glucose. And in the right side, this is congestive heart failure. An example, recently Barbara Bush contributed to Barbara Bush's death, and you see the loss of the active heart muscles and the ability for the heart muscle to utilize glucose. Now, if you go up on the left, that's a healthy brain, and as you go to the right, you see less activity in the brain and less glucose utilization. On the left side, it shows different substances, and you can see a normal control of an area of the brain that releases dopamine, and you see the healthy activity of the red area. And then as you move to the right, each substances, because it reacts differently in those parts of the brain, do not have that actual utilization of glucose is needed. Other barriers are that we try and use adult size treatment for adolescents, and we need to consider, I'll follow up with an example about NA meetings. Teenagers rarely enter or stay in rehab voluntarily, and up to 85% of kids ages 12 to 17 do not receive treatment. So we talked about AA and NA, and I think the barriers are that their adolescents are underrepresented, they're less likely to join, they don't attend regularly, and they have higher dropout rates. It challenges, their basic idea of independence developmentally. Now, the biggest barrier and confusion in treatment of adolescents is that consent for services. Children 14 years of older can consent if they're younger and they appear to have the capacity for consent. But when you go further into the law, children with psychotropic medications can be used with informed consent of the child, but when they are given, they have to be discussed with the child's legal custodian. And so, and unlike other states, we need, as providers in New Mexico, to involve the parents. Informed consent, as we discussed, this is kind of a simpler version versus the actual law. But if we're going to share information with adolescents, with their parents, we need to have a release of information no matter what their age. For treatment and also for urine drug screens. And at the same time, we want parental involvement because of transportation. You don't want diagnosis to show up on insurance payments. You want them to be involved. What is the evidence? There's growing evidence on the neurobiological impact of these medications on the brain, and in the future, I'll discuss a new study that's has begun, and there's preliminary evidence and emerging consensus that using the use of relapse prevention medications with the involvement of counseling and family can improve outcomes. And this is the study I was talking about. It's currently underway by the National Institute of Health. It's going to recruit 10,000 youths, ages 9 to 12. They're going to follow them over time. They're going to do repeat MRIs, and the assumption is that there will include a subset of children who use substances. So we'll have very clear future PET scans and MRI findings in 10 years from now. So pharmacotherapy, what are the benefits? In the adult population, we know that it improves retention rate, decreases the risk of accidental overdoses, and decreases drug use. For adults, it is shown that methadone is more effective than buprenorphine and naltrexone than psychosocial treatments alone. In adolescents, it also shows the fact that it helps reestablish normal brain functioning, reduce cravings, and prevent relapse. This is an example of that in heroin-controlled subjects. You can see a change in an adolescent with health without substance use than an adolescent with. Suboxone, this is very controversial, even in adults. It's approved for individuals 16 years and above. It's a partial agonist and antagonist, and with a high affinity for the opiate mu receptors. It is actually combined with naloxone. It's sublingual, and this it's sublingual films as well that prevent IV injection, except for Subutex, which is buprenorphine alone, and we use that with pregnant women to reduce exposure to two different substances. Most patients require between 8 to 16 milligrams. Some people prefer split dosing, which isn't really consistent with the length of time that Suboxone lasts or its half-life. It's absorbed 51% sublingually. In the GI, it's 15%, and IV is 85%. So that's why it's put with naloxone, so that it is not injected. It is a higher cost, and it's only detectable on a specific drug screen. There's less sedation and less likely to overdose because of this ceiling effect. Adolescents on Suboxone, this is a 2014 study from the Journal of Addiction Medicine, and it included 103 kids, mean age of 19.2 plus or minus 2 years. Retention was the largest barrier to success, but they found long-term sobriety in patients with ongoing Suboxone treatment, and they measured this by urine drug screens that were negative for opiates and marijuana and positive for Suboxone. Naltrexone, now this is called a competitive antagonist, and it actually blocks the opiate receptor. It's not scheduled, but it is only FDA approved for ages 18 and above. You have two modes of use, oral and monthly injection. It can cause abrupt opiate withdrawal in patients who have opiates in their system. For example, if someone's in a car accident and they go into the ER and they're given opiates, they will go in severe withdrawal. It's also used for alcohol use disorder, and one of the major differences is naltrexone helps cravings in alcohol use disorder, but not as significant with opiate use disorders, but it does decrease the risk of accidental overdose. Methadone is Schedule II. It's most controversial. It's a full opiate agonist with long half-life. It can only be prescribed for opiate use disorder and outpatient opiate treatment programs like our clinic, but it is used in the primary care setting for the treatment of chronic pain, and it is the #1 source of illicit methadone use outside of treatment programs. It's the gold standard for opiate addiction treatment since 1970s, but because of its side effects, there's increasing use of Suboxone. We really encourage that in our program because of the side effects of respiratory depression and QT prolongation, as well as the obligations to use that. Thank you very much. These are my references. I'd like you to refer you to websites on the second list of references. One is the SAMHSA website. There's a really good opiaterisk.com website, and the Health State of New Mexico website. There's a if you go to NIDA, there's a full guide from them that calls the principle of adolescent substance use disorder treatment. Thank you very much.